Good morning, good afternoon, good evening, wherever you are. My name is Jan de Geer and I welcome you to the 2022 Matrix Online Seminar Series. Matrix is Australia's National Research Institute for the Mathematical Sciences, and we're sponsored by the Australian National University, Monash University, the University of Melbourne, University of Queensland, ACENS, which is an ASC Centre of Excellence for the Mathematical Sciences, the Australian Research Council, and the US-based Simons Foundation. Before we start, I would like to acknowledge the Wurundjeri people of the Kulin Nation, who are the traditional custodians of the land on which I live and work here in Melbourne, and pay my respect to their elders past, present and emerging, and extended respect to other Indigenous Australians in attendance. Today, we are very pleased to start the seminar series with Professor James McCaw, who will speak about epidemic modelling to support Australia's COVID-19 planning and response. Professor McCaw is Professor of Mathematical Biology at the University of Melbourne, with appointments in the School of Maths and Stats, the Melbourne School of Population and Global Health, and the Doherty Institute. James is an expert member of the Australian Health Protection Principal Committee and contributes to Australia's response to the COVID-19 pandemic through the provision of advice to key national committees based on mathematical modelling, on which we'll hear about today. James welcomes questions during and after the talk, and you can submit questions via the Q&A function, after which you'll be invited into the seminar and we'll enable your audio so you can ask the question verbally. As a final note, I want to say that this is a seminar primarily intended for the mathematical scientists and a broad academic audience. Journalists or others who are in attendance are asked to consider all the material that's presented here as commentary and background, and the views expressed by the speaker are his personal views and do not necessarily reflect those of government. With that said, I now want to hand over to James.
Thanks, Jan, and thank you to Matrix for the opportunity to give this presentation today. I'll share my screen shortly. And it was, I think, April 2020 when I gave a first Matrix seminar on pandemic preparedness and modelling. It was a long time ago, and obviously we've now, myself included, we've all lived through really what's been two amazingly tumultuous years globally and, of course, in Australia. In my seminar today, I'll look back on some of the very early work we did in 2020, and it's primarily focused on some of the results from that first year of the pandemic. It is a reality of how I work, that we do for government needs to go through various processes. So I'm unfortunately not able to provide any details of a lot of the more recent work that we've done, including on Omicron, but I will make some comments at the end on those matters, but I can't show sort of more up-to-date results. It's just not something that's possible. And just before I'll also bring in at the end of the talk some work that we've done in our region, so in French Polynesia in particular, because I think it's a nice demonstration of some of the methods that we also apply in Australia. So that's just for towards the end. Okay, so I'll share my screen. And I hope that's they're clear. If it's not, Jan or someone from Matrix, please just let me know. And I'll also just, I have an acknowledgement slide at the end, but look, I'm presenting some work and outputs from a really huge team of people. In the end, I'll probably touch on work that's been done by more than 50 different people across Australia, from mathematics, statistics, epidemiology, computer science, with a lot of support from people who are trained in clinical medicine, who have worked with us all the way through, and public health professionals. So I'll acknowledge them at the end, but I certainly can't cover all of everyone, and I'm sure there's people missing from that list at the end. So how did we start estimating likely or possible impact of COVID-19 in Australia and anywhere in the world, really? And this is work that was done in January 2020. And I haven't looked at it for a long time until I went to prepare this talk, really. These are some simulations from really a pretty simple SEIR type model that we presented to government in late January and very early February, I guess, in 2020. And what we were looking at, it was based on early estimates of the effective or the reproduction number, the R0 out of China, which was around 2.5 at the time. And so that's for the ancestral Wuhan strain. And drawing on the duration of infectiousness, essentially, and so something called the generation interval for the SARS coronavirus, which we already knew this SARS-CoV-2 COVID-19 virus was very much related to. And this is what we presented to government to try and help them understand that there was something to worry about and that some action early could make a large difference. So we didn't know anything about clinical severity at the time. So we looked at mild and moderate and high severity, which has escaped me, actually. I should have looked it up, what those values are, but they're essentially the probability of an someone who is infected needing medical attention, and it's varying over orders of magnitude across these 3 rows of the slide. And one of the things that we looked at very early on, because we weren't willing to make an assumption on it, we needed to, was whether or not there was infection or people became infectious prior to developing symptoms. The reason we looked at these two, so this is the left and the right on the screen, the reason we looked at the two is it was known for influenza, the virus influenza, that about half of all infections occur prior to symptoms, and then the other half of infections occur post-symptoms. But for the 2003 SARS virus, or the SARS outbreak from almost 20 years ago now, it had become very clear that people were not infectious until after they just developed symptoms. And in this model, we captured when people would show symptoms, and then if they showed symptoms and we had isolation, we were reducing their onwards contagiousness. And clearly, if people are infectious prior to those symptoms, then it's harder to manage and control that epidemic. And this slide, essentially, which is a very, it's simulations from a very simple nonlinear dynamic model of SIR type, actually was important because what it showed the decision makers was that relatively small changes in infectiousness, so going down by 25% in red and 50% in purple or blue, would dramatically change the shape of an epidemic. These are large epidemics in which there's no changes in, say, people's behaviour or not. So these are the first example, and I'm going to come back to it many times in this talk, examples of where epidemic models are not there as predictions of actually what an epidemic will do over a long time scale, but rather showing that you can or cannot make a difference to how the epidemic might behave based on certain different sorts of interventions or policy reactions. The other reason I have put this up is that, of course, this never eventuated. We did not see a large, massive wave. You can see daily presentations here are up into the hundreds of thousands. We didn't see this in 2020, but of course, and for reasons that we well understand and I'll revisit shortly, but of course, this is not entirely unfamiliar if we think about what Omicron is now doing around the world, but more particularly in Australia. So this was really a catalyst to act. It said if we can find ways to reduce people's infectiousness by 25 or 50%, we can flatten and extend the curve and save lives, and the peaks are lower, so the hospital system would, have less burden on it. So just a little bit more information. This model then, we developed this up into something slightly more sophisticated, and here's just a picture of it. I'm really going to focus, I'm not going to put really many equations up today at all, because I want to cover off little bits of, I think, what are quantitative insight from lots of different models, and so I'm sort of keeping it fairly conceptual. So this is the model that ended up being part of the key response back in early 2020. So we have susceptible individuals, and along the top row, they go through an exposure period. So this is when people have been exposed, but they're not yet infectious, in these beige boxes. And lambda here, just don't worry too much about this this factor here. It picks up all sorts of other things that tell you how the number of contacts and people's behaviour sends people down this top row, which is around infections which are passively detected because of, say, symptoms, and people who are in quarantine. So this is like a contact tracing process, and the more effective the contact tracing process, the more people go down this lower path and across this top path. And lambda is the force of infection. So this is where this model's nonlinearity hides, because lambda is a function of the red infectious states. It's a linear function of them. So lambda is some constant multiplied by the value of these different compartments. So essentially the number of infectious people. And so what that means is just standard SEIR model, really, that the rate of flow out of, or the flow out of the susceptible class is a function of both the number of susceptibles and the number of infectious people across all four of these states. So people go through a late or an exposed period where they're not infectious, and then they become infectious. And we have two phases of this infectiousness here, mainly so that we can capture the effect of isolation. So this is people who test positive, come to the attention of the authorities, and the authorities ask those people to isolate. We can divert those people at some early phase of their infectiousness into a managed isolation, where we assume that they are either not infectious or less infectious, and eventually they recover. And then the nice thing about this model is that we also capture a group of people based on how the contact tracing system is working. A very abstract model of contact tracing system, not data-driven, who become exposed, but they are in managed quarantine. And so by the time they become infectious, they're not outwardly infectious to the entire community. So they contribute less to the force of infection lambda. Of course, those people are also in quarantine, able to be identified and then isolated further, perhaps within the household. And so even less onwards infectiousness from them. So this is just ends up being, we can do an age structured version of this model, and it's a deterministic model. We can run it forward, and we end up with scenarios like this, where we just choose different values of the parameters of those models. And so in February 2020, we considered scenarios only where there was up to a 33% reduction in transmission due to social and physical distancing. We had never seen a pandemic spread in a modern society which prompted people's behaviour changes. And of course, in February 2020, we knew that Wuhan had locked down and people were not mixing, but nowhere else in the world had there been a lockdown. The word didn't even exist at the time. And we certainly didn't consider, nor did any other countries in their plans consider what ultimately happened, which was lockdowns. So we considered here what was really seen as a huge impact on society, the idea that you might reduce people's mixing, which would reduce the factor out the front of in lambda, so that just essentially reduced the reproduction of it by 33% due to social and physical distancing. And what we showed, this is a slightly edited slide from one of the government's press releases back in April 2020 or so, showing that if you just let this virus wash through the the Australian community, you'd have this just simply enormous epidemic wave that would put a massive burden on the health sector. With quarantine and isolation, this can be dramatically reduced, but is still far in excess of the capacity of a health system. These are admissions to hospital, and we have tens of thousands of beds, but people stay at hospital for a while. So these would map to just catastrophically overwhelmed systems. And if we include isolation, which is the thing that the model I've just shown you allows for us to capture the effects of, at least in some rather abstract way, you can get the reproduction number essentially right down to just above 1, and you get this sort of infection, this flattened curve, which some of you may recall. Of course, in here are still millions and millions of infections. And so this is really the pivot point to what I'm going to say is where I've spent a lot of the last 2 years, which is, well, what actually happened? And what we know happened is that public health measures, which were very carefully deliberated at CDNA and AHPPC and committees, and then acted on by the government, were introduced, and they reduced population mixing by, essentially well over 90%. And so we drove the reproduction number to under 1. And so this never occurred, which is a major public health success. And we've been benefiting ever since, right up until, even now, despite the spread of the virus now. So what happened in Victoria in 2020? Victoria is really a particularly interesting state of Australia to look back on. This is an epidemic curve up until sometime towards the midpoint of the well-known Victorian second wave. And what I've done is I've plotted it by overseas acquired cases in dark purple and locally acquired cases in the blue. And unknown, this is just simply that a system is very, the surveillance system and doing all the interviews is very difficult. All of these unknowns are going to ultimately have just been locally acquired, almost all of them anyway. So we consider the green as locally acquired. And so the first epidemic wave, this is back in March 2020, and it looks very similar to what happened in other states and territories, really was a wave of importations. And the local acquired infections really, they spread. There's more of them to the right of this part of and around the peak than there is early on. But when we need to measure this, if we naively just take this epidemic wave as a whole and we estimate the effective reproduction number, which is a measure of, on average, at this moment in time, how many people we think an infectious person is infecting, and I'll just briefly say how we measure it shortly, we would get a very incorrect picture if we assumed all of this was due to local transmission, because really it's due to importations. The way that we look at this is we have independent estimates of the generation interval. So this is essentially the probability distribution of when an infectious person infects people, normalized to 1. And then we take someone from the population who has just become positive, and we ask who could have infected them based on people we have in the earlier part of the surveillance case series, and we look at the gaps between the times of those notifications or those inferred exposure dates, and we look at what the probability of someone infecting that infection event having occurred, and then we look at it for one of the other people earlier in the line list and ask for that probability based on the generation interval. And by doing that, we can reconstruct what the average number of infections that each of those people back in time has done going forward. And we just cycle that algorithm across all of the line list. And of course, if we ignore the fact that some of those people just appeared from overseas, we get an incorrect result. Of course, as well, those overseas people are infecting some of these people in blue. So we need to do the way that we deal with this is a subsampling thing. We believe that the overseas acquired people they're having some influence, and we try and estimate that as well as the local to local. And what happened? So essentially, once we closed the borders, sometime, I don't know when it was, sometime around here, and instituted the measures, we essentially achieved elimination of the virus. So a lot of the overseas acquired in here are within the hotel quarantine system, and so their outwards force of infection is essentially zero. I know we all know about the odd breakthrough, but the expected number of offspring from these people in hotel quarantine is vanishingly small. There's enough of them, so very occasionally we are unlucky. And around here, sometime, essentially we achieved local elimination of the virus in Victoria. And then, of course, unfortunately, there was a breakthrough in the hotel quarantine system. And this is the first real genuine wave of locally transmitted SARS-CoV-2 virus in Australia, is Victoria's second wave. And we could track the reproduction number of this, of the virus, and what we saw, these vertical lines here are the times of policy changes instituted by governments, either nationally or in the state one. So these three here are the stage 3 and stage 4, and I guess back to stage 3 restrictions in Victoria. And what you can see is that the reproduction number was well and truly on its way down already at the time that we introduced stage 3 and stage 4 restrictions in Melbourne's second wave. We drove the reproduction number under 1, and this was the long period of time where we had low diminishing case counts, because on average each infectious person, for every 10 infectious people, we were getting about 8 or 9 new people, and this slowly decayed down to the local elimination that was, just a few months in around October. So this also generated really some very interesting methodological challenges for us, in that measuring the effective reproduction number requires there to be transmission and cases. And Australia, briefly in Victoria, but for vast, very long periods of time in many other parts of Australia, had no cases to measure a reproduction number on. But of course, people were behaving in certain ways, and we knew that there was the opportunity for the virus to get through the hotel quarantine system and start spreading. And so we had to develop or consider, how do we provide a risk assessment to government that captures what we think the virus might be able to do if it were to invade or get into the community. So something like a reproduction number, but measured without actually having the virus circulate. And so that's where a lot of our attention shifted, and all of the credit here, and for all of the details on the mathematics, I refer you to this medRxiv paper, but all of this work was done by Nick Golding and colleagues, of course, including me and Freya Shearer and Jodie McVernon here from the University of Melbourne, and David Price at the Doherty Institute. And this work has really become quite important in how Australia conceptualises and manages transmission. So this is the work that introduced the concept of transmission potential. Oh, my screen's just gone quite strange. Okay, I think I'm back. Sorry. So, I apologize. Okay, sorry about that. So the transmission potential, the idea behind it is, we know that the virus spreads through social contact. It's a respiratory virus. We need to come broadly, we need to come into contact with other people for the virus to spread from one person to another. This is not to get into the discussion about droplets and aerosols, and contact. It is nonetheless the case that if we spend more time with people and we are closer to them, we are more likely to infect them. And we can mitigate that through good ventilation and all sorts of things, but that's a sort of a separate discussion. So what we developed, and Nick Golding was the brainchild of this essentially statistical methodology, is we started to measure everyday daily population mobility data. Google and Facebook and Apple all have been making available aggregate metrics of how people are moving in society. How much time they're spending at home, are they commuting to work, how much time they spend in parks and recreational facilities and at shopping centres, and they provide just time series data on those things to the public. And then what we also did is worked with the Commonwealth Government to set up a set of weekly surveys. So there is a population survey that's been running for essentially the last 2 years every week, that asks people a range of questions on how many people they meet and how they behave when they're out in public. And so what this allows us to do, and I'll give a little bit more information on this shortly, is we can measure through time the number of non-household contacts that on average people are having in the population. And we measure this in all of the different states and territories of Australia. There's a few thousand people sampled every week. And we also, and so what we essentially do is this allows us to develop a metric called the macro distancing metric, which is a measure of the number of non-household contacts that people have on average in each jurisdiction each week. And of course, the more people you meet outside, the greater your opportunities are to spread the virus if you happen to be infectious. And I'll say a little bit more about how that is related to the daily population mobility data from Google in a moment. The other thing our surveys ask is questions on people's behaviours. So how often do you wash your hands? When you meet people out in the community, do you try and keep, say, 1.5 metres away from them? Again, just on the aerosol thing. That question is still highly relevant. It's not to say that if you're more than 1.5 metres away, you can't be infected, but people who, if they report that they are taking that as a precautionary measure, it's strongly correlated with things like other behaviours that people display, and it is definitely associated with how people, with the status of the epidemic. So we can see that it's linked to risk perception, and I guess the methodology we've developed, and I'll show you in a moment, it's highly suggestive that it's also very much linked to the risk of transmission. And so then we also bring in case onset detection times. I'll say more about this at the moment. These data streams all feed into a model of the population average. So this is the transmission potential. The population average over here is the transmission potential. So what we have household contact rates, we have household transmission probabilities, and we have non-household contact rates and non-household transmission probabilities, which are of course influenced by people's essentially how they behave when they meet people out in public. So this will pick up changes due to, say, mask wearing and things as well. And I'll say more about this in a moment, but essentially the case isolation effect, which is an idea, it's purely an empirical, it's a data-driven, non-parametric model showing about how much of the generation interval we cut off, and so how much infectiousness we remove from an infectious person based on asking them or requiring them to isolate. So all of these things feed together to develop a model, and the medRxiv paper gives you pages and pages of description of all of the different components of the model, and the probabilities and all of the different structures, all of the algebra is in there. I'm not going to show it today. And what this gives us is essentially an estimate of what we would predict a reproduction number to be if the virus was spreading in the population at the moment in time. And then what we also do is we're measuring, we have our case time series data, and we can look at how it's, and measure the effective reproduction number in that, and we can monitor the discrepancy between these two. So there's this deviation. And essentially what we're now doing is This is all done in a Bayesian framework. And the transmission potential is essentially acting as a time-dependent, so calendar time-dependent prior on what we believe the effective reproduction number is, so that at times where there's lots and lots of cases, like say now, then the reproduction number that we estimate in this method is exactly the same as one that you would compute with any other method of estimating the reproduction number. But at very low or zero case incidence times, we've got the transmission potential, and essentially, if there's no one around, the ref is meaningless. And when there's a few cases, it's influenced by this, and we can look at how different they are. And that actually has an interpretation, which I'll show on the next slide, or should flow shortly. So just to show you a little bit of really what then comes out of these models. So this is our a time series of the macro distancing outputs, and unfortunately it's only for 2020, and the 2021 bit is fascinating, but I just can't show it to you, sorry. So we have the weekly contact rate surveys, which gives us the number of non-household contacts. We have Google mobility data that from which we learn the relative contribution of various metrics that they report, so time spent at home, time spent at work, time in parks. And what we do is we can use that, essentially it's just a correlation analysis, and it allows us to understand or to predict the number of non-household contacts that people are going to have based on how those Google mobility data streams are evolving. And so that allows us to, there's a statistical model from which this purple line is the output, which is what we feed into our overall models of transmission. And this model can account for holidays, which we expect influence people's behaviour, and so contacts. There's weekend and week effects. There are policy changes which we might anticipate would lead to dramatic changes in people's mixing or behaviour. And we deal with things like respondents rounding off numbers in reported contacts. I mean, if I asked you how many contacts you had yesterday, if you had a very few, you might report it quite accurately. But if you say a nurse or someone in a shop, you might say 100, but you don't know if it was 80 or 200 or something like that. So we deal with this in careful ways, just by thinking about the probability distributions from which we estimate things or model them. And so what we can see in Victoria is that in the period between the two waves, the first import-driven wave and the famous second wave, people's macro distancing behaviour steadily increased. People just met more and more people. And there's a little bit of information from the surveys, which are the grey and black, but this is primarily, trend is driven strongly by what the Google mobility data showed. And similarly, in the second wave, this is what people were reporting in the surveys, but based on what Google was also showing us, we believe that the number of non-household contacts, got at its lowest point down here and then steadily increased as people, this is the end phase of the wave, and this is when we achieved elimination of the virus in Victoria in second wave, and people all relaxed, and so people started reporting, mixing more from Google and reporting more in the surveys. And then this is when the virus got back into Victoria through the link to New South Wales around Christmas time, 2020-21 summer. And in New South Wales, we saw similar patterns. Of course, they didn't have a major second wave, and we can see quite clearly in both mobility and the contact survey results that their behaviour was much more steady across 2020. And then this is the event that happened in New South Wales about just over a year ago, where we saw a major change. So we continue to track these things up until today, like we're still doing. Similarly, we have a micro-distancing model, which is basically just what proportion of people respond to a question of, do you always stay 1.5 meters away from someone when you meet them outside in the house? And we assume that people didn't do this early on. This is quite important in the model, and we don't have any data for, January 2020. But what we can see is there are very strong trends in people's behaviour about how they, this is getting more and more relaxed. So more and more people aren't paying attention to public health advice that you should be careful. And then Victoria's second wave drove a very strong increase back to very high levels of taking care, and then that slowly decayed again as people become less worried, and New South Wales has a different trend. Surveillance effect model is simply, we're looking at, in the line list data we received from the Commonwealth, the relationship between when people said they reported symptoms and the date that they got notified. And this picks up, the earlier someone's notified, the earlier they're isolated, and so the more of their generation, their infectiousness we remove. And so this is an important effect based on people's behaviour and system testing performance that influences transmission. So we put all this together. I've already really said this. It's just, and if you're more interested in the actual statistical model and the structure of that model, I refer you to the preprint. So what does this look like? This is New South Wales in 2020. We have the first wave of local. This is only the locals here. We've got rid of all of the imports, and just stuttering epidemics. If you remember 2020, New South Wales kept on having infections and they kept on getting rid of them. If we look at the reproduction number for local active cases, it was above 1, it was under 1, and it just kept on blipping up above 1 and then getting pushed negative as there was an outbreak and a successful public health response that pushed it away. Over this time, the transmission potential, which we think is like the average, what we expect the reproduction number might be if you just allowed the virus to spread, was just very steadily increasing, and it was consistently above 1 for the entire period of 2020. And what we see with the deviation, so this is just the deviation between the ref and the TP, is that we regularly see it being high, which is an importation event, and then we see it go negative, which suggests that essentially the ref is lower than the TP and the virus isn't spreading as effectively as you might expect. And very different pattern in Victoria. Here's the second wave, which looked big at the time, and of course it's tiny compared to what we've now seen. And essentially in Victoria, we had a long, long period where the transmission potential was well under 1. And so essentially we said, based on how much the average person in the Victorian population was mixing and behaving, the virus should not be able to spread. Of course, the virus was spreading, and we could see this throughout the second wave and the long tail, that the deviation was positive. And what we interpret this as is that the virus found its way into hard to reach communities who were mixing more than the average, and it was harder to get the virus out of those communities. And of course, that is what we know happened. So just to put this in context of some of the headlines, now very old, this big blip here was the cedar meat, so we picked that up very quickly. And then this deviation that was systematic through Victoria is really, it is linked to hard to reach communities and classic public health. So this lined up with the socio-economic and social determinants of health, which are a big part of pandemic response. And of course, at the time, and you know, I'm not putting this up without very much, we know there's some irony here now, but nonetheless, in 2020, New South Wales Public Health was doing a superb job at stopping the spread of the virus where you might have expected it not to. And these dips are very clear evidence of that. So the other thing that we spent a lot of time doing was producing epidemic forecasts. And these forecasts are, you know, there could be a talk, a long talk given by the people who produce these forecasts that could give you lots of information on them. These, we now have an ensemble forecast. So we have 4 different epidemic models that produce predictions of case counts into the future. One of them, which is Rob Moss leads from the University of Melbourne, is a stochastic SEIR transmission model. It reads in the reproduction number that I've just shown you, and it uses something called a particle filter, which is sort of like a computational version of a Kalman filter, to match the past epidemic behaviour. And so it has each particle is essentially an SEIR model at a certain state and with a certain set of parameters, and then that model is run forward and produces a trajectory, and we just and you keep particles which are explaining the past data well, and then you project forward their behaviour. It's a stochastic SEIR model, as I said, and so that projects forward a cloud of trajectories from which we can compute probability distributions for the future. Monash provided a general autoregressive model, so nothing to do with mechanism. It's just based on his, it learns from the global data set on how future cases will depend upon the recent part of a time series. Adelaide, University of Adelaide, Josh is here. I won't even pretend, Ross is here. I won't even pretend to say anything in detail about their stochastic transmission model that they use to calibrate to past time series and then provide projections forward. What I've shown you here is the ensemble across those three models equally weighted for Victoria at what we now know is the time of the peak. And what I had to say to government at this time was, so this is on, say, the 19th of July, is I have no idea what is going to happen over the next month in the Victorian epidemic. And at the time I said that, some people thought, well, what's the point of modelling? And my point was, there's lots of times back here where I was very, very clear that our work showed that we knew we were on an increasing trend, and that this was a time when, as a scientist, it was a very important message for me to deliver that we did not know if the epidemic had peaked and would go up further or decline. And conveying that uncertainty was the key. Later on in the second wave, this was the forecast we had that week. And this was at a time when there were, lots of people, the naive thing to do here is to just fit, say from this last bit of the time series, just fit, say a Poisson regression or some, essentially something that can either only go down or only go up, and predict an elimination time sometime down here. But of course, by taking the models that we've got, either the sophisticated time series models like GAR or the mechanistic models, we know that there's a chance that you can get escalating activity there. And so there was a probability all the way through that late period in Victoria's second wave where there could have been a resurgence. It was a cautionary tale. So what I want to do now is move on to 2021 and some delta and planning. There was a lot of work done on national transition plans. As we all know, this is when vaccines finally arrived. And just as an aside, that we got vaccines within a year and a half or a year really of the emergence of this virus is simply amazing, is what I would say. My view in January 2020 was that we would have at least 2 to 2.5 to 3 years before there was an effective vaccine available. And I'm pretty glad I was wrong. So the idea, once the vaccine was available, the obvious question was, how do we use it? And that this is when the Doherty modelling became a very common thing being discussed in the media. It's been discussed so much, I'm not going to say a huge amount about it. But some of the other bits of work we did here were on test, trace, isolate, quarantine targets. We used some branching process models here, strongly data-driven. Around vaccination targets that were set, the models we developed were highly abstract. They're like the work from January 2020. We include vaccine effects, but of course we're not trying to predict actually what would happen because the models there don't look at behavioural changes and things like that. Sort of a nothing slide there. I did want to briefly say something about contact tracing. So the way that we capture things like contact tracing is when someone's exposed, so they're infected at this time here, the blue period is their latent phase. So this is when they're exposed, but they're not yet infectious. And there's a probability distribution for this, which is really important. I'll talk about it on the next slide. And then someone's infectiousness essentially increases, symptoms start sometime here. This is just a cartoon. And then people, their infectiousness trails off over about a week or so. And how people feel is quite different. They might be sick. They might even be in hospital way out over here. So our passive detection systems, which are based on going and getting a PCR or now a rat and discovering that one is positive and therefore isolating, what they do is, so your symptom onset's here, you've done all of this infectious, you've got this infectious potential here, your test is here, you isolate, and this is the part of the probability distribution that we chop off due to isolation. But there was still a lot of infection coming here. The reason that contact tracing is so effective and so important is that if you have someone who's being monitored through active detection, so you get someone gets a case is identified, the contact tracers ask questions and find out who you've been in contact with, and those people are then tested. It means that someone might be tested here, someone who is truly infected gets tested here well before their symptom onset, and we remove all of this part of their infectiousness, and this is the only bit that's left. And so, you know, this is just conceptual, it's pretty straightforward. Of course, we actually have information on all of these different probability distributions and this distribution here for the exposure or the latent period. And we can feed all those distributions and do the sampling from them and feed those results into big agent-based models or other calculations and essentially measure how effective TTIQ is, and then feed that into the hierarchy of models to then say why we do or don't need it and what the consequence of having TTIQ working or not working are. I might, in the interest of time, skip over that, but that's essentially how we construct, how we deal with the probabilities of events happening and feed that into decision making. One place where this, just coming back to the latent period, is really important is historical now. It's around border measures. There was a question at some time in early 2021 about, once we have people vaccinated, should we have, can we reduce the quarantine period from 14 days to 7? Because they wanted to essentially have more people coming through the border, or the idea was that the vaccine reduces your infectiousness by, say, 90%, so surely we can reduce something, which is a very dangerous idea because the quarantine duration, 14 days, picks up about 99% of people who will ever test positive, have tested positive within 14 days, but it's far fewer within 7, because a lot of people's incubation period is you know, 5, 6, 7 or more days. And so we did some very, very simple calculations, just draw on from the probability distributions we know, and what we did is presented these sorts of figures. So we said, if you've got 14-day quarantine, 3,000 arrivals a week, and there's a transmission potential in the population of 2, how often will you have no outbreaks occurring? You know, it's essentially a breach plus consequence, and you know, 80% of the time you're fine, and occasionally you'll have 1 or 2 or more outbreaks that you have to deal with, say, mop up and re-eliminate the virus. And we pointed out, if you doubled the number of weekly arrivals to 6,000 people, it makes very little difference to these, because the 14-day quarantine is continuing to capture the people. But if we drop down to 7-day quarantine, all hell breaks loose. And so this is compelling, and these sorts of calculations are what you know, a big part of the decisions to make sure that that border quarantine system stayed in place throughout 2021. Okay, I really want to say something about French Polynesia. I know I'm about to run over time, Jan, but because this gives me an opportunity to talk a little bit more about some of the forecast performance. So French Polynesia is very interesting. This is its incidence up to 21st of October 2020. Small place, but it had clearly a growing epidemic. If we estimated the reproduction number based on this, what we said was, in green is our estimate based on complete data. We have to do a nowcast because these daily case counts are about infections that happened in the past, of course, because it takes a while for someone who got infected to get tested and then get notified. But, you know, clearly a growing epidemic. A week later on the 4th, or a few weeks later on the 4th of November, it started to look like this. You can see there's days of the week, there's all sorts of issues with this data stream. And so but you certainly see this looks like it's starting to plateau a little bit here. And the reproduction number is above 1, but it's dropping. And so what we can do is feed that into our forecast. So this is the SEIR particle filter forecast. This is the backcast of the model. So we can see the model is capturing the data very, very well. And if we assume the case ascertainment of 20%, so 1 in 5 infections in French Polynesia was being recorded in that data stream, then this is the fit and this is the forecast, because at 1 in 5, actually, this is an epidemic. This is enough to drive susceptible depletion. So the SEIR model's nonlinearity says this is what's going to happen in the future. Some chance of sustained, but not much more. If we assume 50% case ascertainment, this is the backcast, the fit essentially, and this is what we predicted. And the red dots at the time that this was produced are what did happen. And actually, I can't tell, both of those look reasonable to me. We also fed those few things through case ward and ICU occupancy, things based on what we believe would happen, mapping cases to hospitals. Up to the 19th of November, it was definitely coming down now. Negative reproduction number under 1. And then 15th of March, so this is, we'd seen the full epidemic. And so what we were able to do is revisit, the red is what ultimately happened, and these are the different forecasts that we would have had back at this point in time, based on different case ascertainment. And you can see it really matters. And so this has clear parallels to where we are at Australia in the moment, that depending upon what case ascertainment has been for Omicron is really important for predicting what might be happening in the future. And really the only way to figure out between these things is to do empirical studies to measure exposure in different ways. So Omicron, vaccine escape and increased intrinsic transmissibility. This is really quite surprising that its intrinsic transmissibility is higher. So with vaccine escape has meant that's why Omicron spread. Thankfully, it's got lower clinical severity. And third doses and boosters are suppressing transmission and providing enhanced clinical protection. But really what's on the horizon is that vaccine efficacy wanes and it's rapid for transmission, and behavioural changes need to be monitored. And of course, any new variant could completely change everything again. And I'd just like to remind you about this figure that we did back in 2020. And Omicron is essentially behaving rather like this. This is where we are now, but we are in a vastly better position than what we ever were because we've got the vaccines and we've sort of weathered the storm for 2 years, so that now, despite the challenges, we're in a better position. I forgot I had the slide, and I would like to say something about it. This is the infrastructure that ultimately we've built up in Australia over the last 2 years. There's all sorts of data sources: social behaviour, testing data, line list data, household data. This feeds into what I've focused on in this talk, which is SIT assessment. So we do analyses of RT, we do first few hundred analyses, we do forecasting ensembles. These things all link together. I don't know what other analyses are. And then over this side, this is the Doherty modelling and some of the scenario planning. We have intervention analyses that ask, in certain situations, often rather abstract situations, what are the sorts of different strategies we should employ? And then all of that feeds up and down in a complicated place to different decision-making bodies. And actually up here is where I spend a lot of my time thinking about how to interpret this middle layer and feed that to decision makers. And what I'm going to say is this link here between SIT assessment, so data-driven computational statistical analyses that are informed by mechanistic models, and how that links to the more abstracted scenario analyses is a huge methodological gap, at least in our team. There are some groups that do this much better than ours, but we don't have a strong connection yet between SIT assessment and intervention analyses. So just to wrap up, scenario analyses are really there for planning, and real-time SIT assessment is there to support the response over the short term, and how they interact is really quite complicated. And there's lots of room for improvements, including kind of fundamental methodological improvements, I think. And in all of the communication on these things, I'm always working on the balance between illustrating possibilities and conveying uncertainty. And I tried to point that out with the forecast in Victoria. There's a huge challenge in communicating model horizon times. The idea that the pandemic is going to go on for years is hard to understand, and then how you then don't paralyze society but also continue to be ready to respond is tricky. And the one thing I'll just pull out here is decision makers are skeptical, in my experience, of models that include everything and that are framed as you should do this. And I think a lot of the benefit of the models has been this is what you should be aware of, and here are ways that perhaps abstracted models or principled models can help you make a decision on a certain topic. But models that capture everything and say, so here's right now we should do this, are too much of a black box, and people do genuinely want to understand why they would make a certain decision. And I've mentioned that. So acknowledgements are long, so I won't go through them all, but I couldn't.
Thanks, James.
Yeah,
and
thank you, Jan, and thank you all.
Hope to see you all back on the 1st of March when Professor Bhargav Bhatt from Michigan will present his seminar. Bhargav is a winner of the Breakthrough Prize, so that'll be interesting as well. Until then, have a safe journey. Bye-bye, everyone.
Thank you. Bye.